This is a long form article by Ali Alexandra and Seb Solomon. Um, I appreciate the in depth look at some really important issues. Um, this first part is about healthcare, and it's an issue definitely which is super important to myself. And it's been like this prominent issue we've been discussing a lot actually. And of course, greed and um, messed up ideologies are and lobbyists and things are leading the day here. Anyway, enjoy. Future of Healthcare: Digital Ethiopia, China, and Global Technocracy by Ali Alexander and Seb Solomon. The healthcare system in the United States, thanks to the Centers for Medicaid and Medicare Services, or CMS, is pushing to continue moving towards value based healthcare, which is insufficiently described as a model where hospitals and physicians are paid based on patient health outcomes. Even in the current Medicare for All Act of 2021, H.R. 1976, endorsed by the progressives in Congress, Section 501 states that all standards and quality measures under this act shall be performed by the Center for Clinical Standards and Quality of the Centers for Medicare and Medicaid Services, CMS. And if CMS is in charge of measuring the quality of services, it will undoubtedly be a value based healthcare system. While this push began in 2010 with the Obama administration, it has recently come back into the spotlight under Joe Biden. For the record, this is not an endorsement of Trump's solution to healthcare either, because he had no qualms with CMS. In fact, according to the CMS administrator, Seema Verma, President Trump made it clear that he wanted to protect and strengthen Medicare. Furthermore, it was under the Trump administration when Seema Verma wrote an article exclaiming how committed she was to using every tool at her disposal to move healthcare system towards value-based care. This is not only a priority for CMS, but under the leadership of Secretary Azar and President Trump, the entire administration is aligned towards achieving this goal. Given that millions of Americans are already on Medicare or Medicaid, it's safe to assume that the Biden administration has plans to salvage and expand what is left of Obamacare. While this might not be the most glamorous topic, it is one of vital importance because there are several issues at hand regarding reforming healthcare, and many supporters of Medicare for All are silent or unaware of these problems. What are the measures and quality standards that frame the Medicare system? Who decides those quality measures? What will the roles of AI, technology, and data collection have in determining healthcare plans moving forward? What role does public health play in terms of managing population health? And how will that play into patient-centered care? What are the metrics and measures that outline how someone is evaluated based on their health? There are many questions that need to be addressed before moving forward with any type of substantial healthcare reform. Only then can we truly understand how industries like healthcare and wellness actually work, and why the notion of universal healthcare may not be as utopic as it appears. In our current society, the ones who have the most to lose from actual social and structural change are the ones in charge of designing and implementing those very changes. Worse yet, the current leaders in government, healthcare, education, nonprofits, and big business have taken the value-based approach and applied it to almost everything imaginable, while their motives remain the same: profit and control. Harvard Business meets healthcare. Pay for success, PFS models reward hospitals and doctors for their performance rather than their services, while previous models of healthcare incentivize hospitals and doctors to provide, quote, unnecessary procedures, end quote, in order to make as much money as possible from patients or Medicare, Medicaid. PFS models largely stemmed from the Affordable Care Act that passed in 2010, also known as Obamacare, rather than address the costs themselves. Business consultants and financial gurus were brought into the Obama administration to address the issue of healthcare costs. One of the leaders during this time, though not directly affiliated with Obama, was Harvard Business School professor Michael Porter. Together with Dr. Thomas Lee, Chief Medical Officer at Press Ganey Healthcare Services Company, they developed a new way to look at healthcare through a business lens, which gave birth to value-based healthcare, a restructured healthcare delivery model that is organized, measured, and reimbursed. You can read more about the general idea behind value agendas via McKinsey. Similar to the ideas behind pay for success or impact investing, VBH, value-based healthcare. So we have PFS, which is pay for success, and now we're looking at VBH, value-based healthcare. Relies on multiple stakeholders for funding, implementation, and data collection, utilizing, quote, data-driven, evidence-based approaches to healthcare confine the terms and conditions to a set of rules that are generally picked by the same people running the whole program. According to Michael Porter, VBH produces better outcomes because the way most healthcare systems are set up, the business model is to offer as much service as possible. That may foster inappropriate care and unnecessary and costly procedures. Concentrating on the best procedures based on clinical studies may be a better approach and one of the most powerful vehicles in lowering healthcare costs. Moreover, this permits access and communication among all involved parties, including with patients. Architecture that allows easy extraction of outcome measures, process measures, and activity-based cost measures for each patient and medical condition. This is their words. And we have a nice picture. I'll also try to include. Porter essentially reduces the healthcare problem to merely cost. The general narrative is controlled by CMS, or the Centers for Medicare and Medicaid Services, who have their own agenda and are the same group who would be in charge of any future Medicare programs. The definition of value, in the sense of business, defines whether you are worth the value or dollars spent on you. Shouldn't the only focus be the patient? Moreover, your value simply relies on how much you are worth, based on dollars spent and dollars expected to be spent on you in the future. Does anyone see an issue with this? Value-based care models reimburse healthcare providers or penalize them based on quality and cost of care. For example, consider a hospital that works under HVBP. The CMS would evaluate the hospital based on numerous criteria, such as immunization rates for certain diseases, Medicare spending per beneficiary, and even patient feedback on their experience at the hospital. Then, depending on how the hospital scores for population health management compared to established baselines, the CMS will either reimburse the hospital on top of their typical fee-for-service payments or penalize their Medicare revenue. This encourages doctors to merge with larger hospital systems rather than continuing with their own independent practices, and incentivizes them to reduce services for patients who may end up needing those services in the long run, all in the name of staying in the good graces of the CMS. These networks then coordinate multiple systems of care, allowing them to access the benefits and bonuses given out by CMS. As already established, the CMS is the single largest advocate for all health programs to move to value-based healthcare systems. Why? Because the problem is being defined by people like Michael Porter, who believe that the root cause of illnesses is the lack of money preemptively spent on people who will be costly down the line. Under this structure, the determinants of patient satisfaction with their healthcare experience are not set by the patients or doctors. They are set by HHS, CMS, hospital executives, legacy universities, and public health professionals. Why does value-based care put the quality of outcomes first by tethering reimbursement to this metric? And will this really incentivize, quote, healthcare providers to prioritize patients? Let's take a look at some clips from the CMS Physician Quality Program Strategy document. While this is updated every year, the 2015 version had the most comprehensive outline of what value-based care actually looks like and why quality measurements might not always be as ideal as they sound. Patients, caregivers, and healthcare professionals will be deeply integrated in the shaping and implementation of measure development, reporting, and quality improvement initiatives. And then also, CMS aims to continue leveraging quality measures to motivate this kind of engagement across the care team and to weave all stakeholders into its process for defining meaningful quality measures for CMS programs. It says, patients, caregivers, and healthcare professionals are key contributors and active participants in measure development, reporting, and quality improvement efforts. Patients, caregivers, and healthcare professionals will be deeply integrated in the shaping and implementation of measure development, reporting, and quality improvement initiatives. CMS will increase opportunities for input from stakeholders through a variety of mechanisms. These could immediately include participation in open door forums and working groups on specific initiatives or programs, and in the future could include continual open-ended input opportunities such as web or mobile-based feedback functions. While getting input from individual stakeholder groups is important in the measure development process, CMS believes that it is equally critical to have these stakeholders together at the table in order to develop consensus around key measurement or public reporting topics. CMS will continue to explore ways to foster deeper collaboration between patients and healthcare professionals through the measures used in its physician programs. CMS measurement efforts to date have demonstrated that measures of care, coordination, and engaging patients as part of the care team motivate true communication and collaboration among patients and healthcare professionals. CMS aims to continue leveraging quality measures to motivate this kind of engagement across the care team and to weave all stakeholders into its process for defining meaningful quality measures for CMS programs. I don't think they really care much about the patient's input. I think that's just, they put that word in there and a lot of other words in there to make it sound nice. The core tenet of value-based care is that it places emphasis on the quality of care rather than the quality of care provided, and an increase in the quality of care necessitates an increase in patient satisfaction, an important benchmark for healthcare providers and administrators. A healthcare organization offering value-based care that comes with an increased rate of patient satisfaction is more likely to retain patients and achieve higher scoring metrics than its competitors. Furthermore, a healthcare organization with streamlined processes and reduced waste is more likely to retain higher quality talent. Dr. Ezekiel Emanuel, The Nazi Roots of Obamacare and Social Determinants of Health. Remember the word value was pointed out at the beginning of the article, well, who is deciding the value of people's lives? Does all life not have value, or only certain lives? What makes you valuable or worth the cost in terms of preserving and ensuring you have the best possible chance at living well? Let's look at this article by Matthew Eret on the issue of Dr. Ezekiel Emanuel, Obama's former health advisor from 2009 to 11, who has reemerged with the Biden administration to advise on the future healthcare structure, implementing measures like the complete lives system. We may need to take another look at how people's health is evaluated in terms of considering how to treat patients. As it stands, the individual most responsible for reviving Obamacare and the associated Independent Payment Advisory Board, IPAB, of cost-effectiveness experts under Joe Biden is the same figure who crafted the original Affordable Care Act in 2009. While acting as Obama's health advisor from 2009 to 2011, Ezekiel Emanuel wrote a bone-chilling study called Principles for Allocation of Scarce Medical Interventions in The Lancet. In this revealing document, Ezekiel's vision for a new ethic of healthcare management was enunciated with the complete lives system that would be used to justify who among the needy of society competing for scraps of the shrinking pie will receive care, i.e., extensive cancer screenings, treatments, drugs, who will be left to die. When he wrote, when implemented, the complete lives system produces a priority curve on which individuals aged between roughly 15 to 40 gets the most substantial chances, whereas the youngest and the oldest people get chances that are attenuated. Quality adjusted life years and death panels. Ezekiel Emanuel made the point in his 2009 report that the key to cost-cutting in healthcare would be found in the application of quality adjusted life years, QALY. The QALY system that itself pioneered under Britain's National Institute of Clinical Excellence, NICE, see that? Right, that's actually spelling NICE, and Liverpool Care Pathway System, which were driving forces behind the corruption of Britain's national healthcare system, NHS, from 1999 to present. The former head of NICE, Sir Michael Rawlins, defined qualities, or QALYs, as in the following terms. In March 2009, interview with Time magazine. It's based on the cost of measure called the Quality Adjusted Life Year. A QALY scores your health on a scale from 0 to 1, 0 if you're dead and 1 if you're in perfect health. You find out as a result of a treatment where a patient would move up on the scale. If you do a hip replacement, the patient might start at a 0.5 and go up to 0.7, improving 0.2 points. Whatever. You can assume patients live for an average of 15 years following hip replacements, and 0.2 times 15 equals 3 quality adjusted life years. If the hip replacement cost 10,000 euros to do, it's 10,000 divided by 3, which equals 3,333. That figure is the cost per QALY. That's from an article by Matthew Eret called Nazi Healthcare Revived Across the Five Eyes. Matthew eloquently explains how Ezekiel Emanuel's fondness for the application of quality adjusted life years, or QALYs, metrics originally pioneered by the British National Healthcare System, or NHS, are morally unsound because those metrics would be used to justify who among the needy will or won't receive care. In his article, includes an unsettling quote from an essay written by Emanuel called Principles for Allocation of Scarce Medical Interventions, where Emmanuel asserts that the death of a 20-year-old young woman is intuitively worse than that of a 2-month-old girl, even though the baby has had less life. The 20-year-old has a much more developed personality than the infant and has drawn upon the investment of others to begin as yet unfulfilled projects. Adolescents have received substantial education and parental care, investment that will be wasted without a complete life. Infants, by contrast, have not yet received these investments. It is terrible when an infant dies, but worse, most people think, when a 3-year-old child dies, and worse still, when an adolescent dies. Wow. It's crazy how some people think, and it's no wonder why this guy's in charge. Ezekiel Emanuel seems to have a Malthusian and cynical view on humanity. He sees human beings as state investments who are only as necessary as the labor they can provide. This line of thinking echoes the sentiments of Dr. Gerhard Wagner, a Reich doctor's leader in the time of Nazi Germany, who in a 1936 speech declared, "The millions and billions that Germany has spent in the past and the about 1 billion marks that Germany will sacrifice today for the care of the genetically ill is a squandering of Germany's national resources that the National Socialists cannot justify when they consider the needs of the healthy population. Thus, we have a good conscience before the world when we eliminate lives that are unworthy of life." Similarities in the logic used by both Dr. Gerhard Wagner and Dr. Ezekiel Emanuel regarding human beings and how people's worth and or value should be calculated is frightening. This is especially true considering Dr. Emanuel was one of the main architects of Obamacare and is on President Joe Biden's COVID-19 advisory board. Dr. Emanuel more or less said that the death of a baby is not as tragic as the death of a person in their 20s because the state has invested more money on the person in their 20s than a baby. Therefore, it is less resources wasted. Similarly, Dr. Wagner believed that Germany should not use the already scarce materials and supplies on taking care of the genetically ill, because that is a squandering of valuable resources which could have been used on healthy people. The point is, a healthcare system that purposely incentivizes meeting specific measures and metrics designed by nefarious people, which is a strong word, but considering all of the profit extraction and lobbying situation and things like that, I don't know, it's basically deserved. Who don't seem concerned with ethics is certainly worrisome. While the prior model of pay-for-service PFS had its own fair share of problems, value-based care seems to be an equally alarming antidote to addressing the cost of healthcare, as well as the general well-being of patients. Given the current standards and measures available, healthcare with a more holistic approach does not receive much coverage from the mainstream or alternative media when talking about solutions. This is a problem. Below are a list of how quality measures are evaluated from a National Healthcare Quality and Disparities Report from the U.S. Department of Health and Human Services. Do these seem extremely vague to you? It's 6 criteria and it is ridiculous. I'll read the first 2. I'll include it again. Person-centered care. Almost half, 14 of 29 of person-centered care measures were improving overall. Patient safety. Nearly half, 12 of 26 of patient safety measures were improving overall. As if value-based healthcare wasn't already cause for concern in terms of who is prioritized when it comes to treatment, the data-focused and outcomes-driven payment system incentivizes providers to spend more time aggregating and sorting through data metrics rather than spending time with patients. Lastly, when healthcare and business are infused into one strategic plan that is outcomes-based, it begs the question, are we determining factors prior to treatment that might influence the methods of treatment in the first place? Also, how can individual physicians afford to stay afloat when the emphasis on data collection in order to get payments from Medicare or Medicaid is steering the ship. Wouldn't the best outcome for any patient be up to the patient and doctor to decide? Lately, there has been a push to include a more holistic approach to healthcare through CMS measures, which include mandates that use social determinants of health as part of the evaluation process. While this sounds wonderful on paper, let's remember we're dealing with profit-motivated entities. Social determinants of health, healthcare quality, and delivery affect each person's healthcare outcomes, but many other factors contribute to individual health. An integral part of delivering high-quality healthcare is understanding the social determinants of health, SDOH, of patients and of communities in which healthcare is provided. The World Health Organization defines SDOH as the conditions in which people are born, grow, live, work, and age. SDOH can be discussed in the following context: social context, demographics, social networks and supports, social cohesion, discrimination based on race, ethnicity, religion, sex, and gender identity, community safety, criminal justice, climate, civic participation, economic context, e.g., employment, income, poverty, education, quality of daycare, schools, and adult education, literacy and high school graduation rates, English proficiency, physical infrastructure, housing, transportation, workplace safety, food availability, parks and other recreational facilities, environmental conditions, sufficiency of social services, healthcare context, access to high-quality, culturally and linguistically appropriate and health-literate care, access to insurance, healthcare laws, health promotion initiatives, supply side of services, attitudes toward healthcare, and use of services. This report examines SDOH by highlighting disparities experienced by various subpopulations. Policymakers, researchers, providers, and other stakeholders can use this report's analysis to understand the outcomes for racial and ethnic, insurance, income, and residential location groups. The recent emphasis on the social determinants of health, SDOH, is concerning for a multitude of reasons. How will healthcare providers assume the roles required for the conditions listed above? Who is determining these standards and collecting this data based on racial, ethnic, religious, and gender-specific information? This type of data collection is also emphasized in the Medicare for All Act of 2021, which stresses the director of the Office of Health Equity must monitor, track, and make publicly available data on the disproportionate burden of disease and death among people of color, disaggregated by race, major ethnic group, tribal affiliation, national origin, primary language use, English proficiency status, immigration status, length of stay in the United States, age, disability, sex, including gender identity and sexual orientation, incarceration, homelessness, geography, and socioeconomic status. Many academics and medical professionals influenced by business consultants at Deloitte and McKinsey believe that the serious health concerns of certain target populations take up 20% of healthcare spending. This framework requires more focus on people who may be at risk in other areas of their lives, specifically within population and social determinants of health. The emphasis on multiple stakeholders operating with patient-first mentality seems at odds with a program like this. Ultimately, these systems mirror pay-for-success models where initial investment is supposed to reduce the spending on someone down the line, because when one controls the measures and metrics, then they can also control what qualifies as a good outcome. If pay for success is described as an alternative mechanism for funding social programs that allows government or other payers to pay for outcomes rather than just for services, and the end payer saves sufficient money when the outcomes are achieved to justify repayment to the investor. End quote. It begs the question, if the goals aren't being met through various mechanisms in use, what's the point? Improvements in overall health and well-being do not necessarily reduce healthcare spending. This is another clip, another screenshot. In most PFS projects to date, the goal has been for the intervention to save more money than the total cost of the initial upfront investment, allowing the end payer to share those net savings with the investor. However, studies of the cost effectiveness and social programs designed to improve health are rare, and improvements in overall health, symptoms, or well being often do not translate into significant reductions in the use of healthcare services or the cost of care. For example, although the preventative services recommended by the U.S. Preventative Service Task Force are considered evidence based and generally improve health, quality of life, and longevity, most of these clinical services do not save the health system money or on net. Cohen, Newman, and Weinstein 2008, Russell 2009. The upfront cost of screening, for example, often outweigh the long-term savings and from prevention of disease, particularly. The Urban Institute even said on their own website that the programs which are designed to improve overall health, symptoms, and well-being often do not translate into a reduction in use of healthcare services or cost of care. If this is the case, then why is there a focus on data collection and social determinants of health rather than addressing the root causes that lead to clinical illnesses? Perhaps the data collection at SDOH have nothing to do with helping vulnerable populations. Healthy People 2030. This program operates within the Office of Disease and Health Promotion and the U.S. Department of Health and Human Services. Healthy People 2030 serves as the guidepost to promote a society in which all people can achieve their full potential for health and well-being across the lifespan. Unquote. There's a graph chart I'll show you in the pictures I'm going to attach in the video. Questions. Yes, who comes up with the measurable health objectives? What are the broad global outcome measures? What is the outcome? Who determines what is qualified as evidence-based? What are evidence-based interventions? Will data collected have any influence over someone's overall value based on the projection of the quality of their life? Lastly, who will be making the overall decisions regarding how data is used? Will AI ultimately decide what data is extracted, depending on the scenario? Worse yet, this study shows that value-based healthcare actually makes conditions worse for the same people it supposedly assists, like minorities and women. Yet even still, the CMS is pushing this type of healthcare payment system as the gold standard. Data collection takes precedent over almost everything else within the healthcare system, which is not shocking given the players involved in the looming digital health ecosystem. The future of healthcare. In Deloitte's vision for Future of Health 2040, they outline the general direction in which healthcare is headed and how data collected from users and patients will be shared with all stakeholders in a patient-centered process. In a short video on the website, they stress that radically interoperable data and open and secure platforms will allow consumers to own their own journey of health by providing them with holistic, real-time view of themselves and their environment, since consumers are increasingly willing to share their personal data through wearable technology and smart appliances in the homes. That sounds like that was AI that wrote that. It sounds great, but again, who is determining what metrics are reason for social workers or public health officials to become involved in people's personal lives? While everything they suggest in this video sounds nice, what is the true intention behind this type of personalized or precision healthcare, and how can it be misused? Furthermore, according to Deloitte, with the collection of more interoperable and secure data, the use of artificial intelligence in healthcare is likely to be a critical engine behind analytics, insights, and the decision-making process. Two physicians from Brown University Medical School, Dr. Vishal Khetpal and Dr. Nishant R. Shah, wrote an article about the negative implications of AI algorithms in hospitals. They describe a clinical prediction tool called the Deterioration Index, developed by Epic, a private electronic health record company and a key supplier of American health data. This prediction tool is now being deployed to different hospitals at an accelerated rate. According to Dr. Kepful and Dr. Shah, although AI has the potential to improve inpatient care by highlighting new links between clinical data and outcomes, it could also oversensitize young physicians to the specific tests and health factors that the algorithm deems important. It could compromise trainees' ability to hone their own clinical intuition. In essence, physicians in training will be learning medicine on Epic's terms. End quote. Furthermore, electronic health record giants like Epic seem happy to provide the data sets required to create a fully functioning automated healthcare system, which ultimately won't rely on any human input. Let's do a thought experiment. What if someone with a low value to society is brought into the emergency room of a hospital with an AI system? Because the value of that person's life is diminished, meaning their lifespan and condition, then based on the algorithms, the person won't be worth any extra investment and will likely be placed into a category of people who receive minimum treatment options. So sure, you're given the best quality of care, but only in terms of the group or category to which you belong. These are the types of issues not being addressed in many discussions regarding Medicare for All. Is holding an opposing view to the established narrative a crime? What would happen if someone's web browser history was tied to their health records? Let's say someone is scared to take a vaccine and their health monitoring system makes a note of their vaccination status. What if they refuse? Who's to say they wouldn't be considered a threat to society and or public health? How did public health and domestic terrorism become intertwined? Please watch this news segment about people who broke pandemic protocols in Australia, then decide for yourself if this is an appropriate reaction to people breaking pandemic measures. It might seem extreme, but if it can happen in Australia, it can happen in the United States. This isn't a statement about whether or not someone wants to take a vaccine. It's about the agency that someone has over their own body and healthcare. When all of these systems are connected, who is to say that someone who is nervous about vaccines wouldn't one day be seen as a terrorist threat? Referring to groups of people as terrorist threats is quite serious. It might be best to judge people on an individual basis rather than make generalizations about the group or category to which they belong. Now let's move on to some other developments in terms of how technology and humanity are merging together in an entirely new way, from digital twins and the spatial web to biometric digital IDs and geofencing. Technology is going to fundamentally change the way we think about humanity and what it means to live well. If we're not careful, we will become enslaved by technocratic overlords and forced to live in a prison-like surveillance state that we will have been fooled into coding ourselves.